Good evening, everyone. Thank you for joining. My name is Pan. I'm the CEO of Centurion. We're just sorting out some technical issues here, so give us one more minute, please.
We have Well in the meeting now.
Dr. Well, are you there?
You should be able to press on your mic.
Yes, hello everyone, good evening. Yes, I can hear you very well.
Great.
Great, perfect. That's very good. We're going to give it, we miss a few attendees here, so we're going to give it one more minute and then we'll start. So please hang tight and yeah, just 1 minute and then we'll get going. Okay. Good evening. Thank you for joining this webinar. Again, my name is Pan. I'm the CEO of Centurion. Centurion is a Swedish medtech company, and we're developing a device, a technology, to help surgeons close the abdominal fascia in the right way. And the topic of this webinar tonight is, are you closing the right way? And I think that's a very interesting topic, and we have a distinguished panel with us tonight that will talk more about this topic and present as well. But before that, we have some ground rules. Meja, please.
Welcome to today's webinar. My name is Meja Heisler and I work as a trainee for Centurion. And today I'm also the technical host for this session and I'll be guiding you through the webinar. So before we get started, I just want to let you know that this webinar will be filmed and the recording will also be available for you to watch afterwards. So if you miss any part of the session, or if you'd like to revisit it, you can easily access the recording at your convenience. And we will begin this with a 20-minute presentation. This will be followed by a panel discussion. If you have any questions during the webinar, please feel free to submit them through the Q&A feature, which you can find at the top of your screen. It's the second icon from the left. Please note that all participant microphones are muted, so questions can only be submitted through the Q&A. And while your microphones is off, you're more than welcome to put on your cameras, but this is completely up to you. Yeah, thank you for joining us today, and we're excited to have you with us.
Thank you, Meja. Next slide, please. And the panel we have with us tonight are these four distinguished doctors. We have Professor Jan Bakkeland from Belgium, a gynecological surgeon. We also have Associate Professor Andrea Stewart from Sweden. We have Dr. Well Hosni from UAE, and the founder of Centurion, and also Dr. Gabriel Berner from Sweden. And as I mentioned, I'm the CEO of Centurion, and I'll be moderating this webinar tonight. Next slide. Gabriel, the floor is yours.
Yeah, thank you, Pan. So why are we addressing closing the abdomen after open surgery? Because about 1/3 of all patients undergoing laparotomy will suffer from complications, and about 20% will have a surgical site infection, up to 7% will have a burst abdomen, and there is a high risk of incisional hernia formation that is 20 or 30%. All these risks is very costly and makes the patient suffer. Next slide, please. So a very common open surgery is cesarean section. That's why we are having this webinar today. About 1/3 of all open surgeries consists of cesarean sections. Worldwide, about 21% of women give birth by cesarean section. Oh, sorry. But that is estimated to raise up to 1/3 in 5 years, and it's estimated that cesarean section will outnumber vaginal deliveries in many regions. Thank you. Next slide, please.
Well,
Yes,
yes.
so thank you very much for the introduction. It's always a pleasure to be with this great panel today. And I'll just go very quickly to illustrate the current situation here in the region, as this webinar is mainly focusing on Dubai and the Gulf region. So the current situation here in UAE, that the rate of cesarean section was around 10% in 1995. This 10% jumped dramatically to 24% in 2014. And yeah, a couple of years ago, it reached around 43% in 2020. So this has been illustrated from the local statistics here in the country. And as you see, those are really high numbers. So the WHO suggests that the cesarean section rate of 10 to 15% should be okay, which is significantly lower than those reported here in the UAE. Of course, in other countries, there are even higher rates than the 40 and 50%. And some countries, like Gabriel just said, that the numbers are outnumbering the numbers of normal vaginal deliveries. So if we look here at the chart for the distribution of birth by sector of delivery, that you will see. So the dark color, the dark green or turquoise, that's the cesarean section part, and the other one, the light blue, is the portion for normal deliveries. And as you see, so in the private sector, you will see that it's 51%. So here they have even cut this into expats and locals, so the nationality of the woman delivering. And but more or less, you will see that the cesarean section will fall in the range of 51%, 42%, 40%, 38%. So the numbers are extremely high. Next slide.
So why is this a problem with the high cesarean section rate? Well, after a midline incision, which isn't very common for cesarean section, we see up to 20% incisional hernia. With a lower transverse incision, we see about a 2% or up to 2% risk of hernia. And I think we as gynecologists don't always see the patients post-operative, so we have a tendency to underestimate the true risk of hernia after cesarean section. Then incisional hernia risk increases also with the number of cesarean sections, and women that have had 2 cesarean sections have a 3-fold increased risk of also going through an incisional hernia repair. And the risk of incisional hernia is increased 6 times after 5 cesarean sections. So cesarean section and the amount of, or how many cesarean section a woman has gone through is definitely a risk factor for developing hernia in the long run. And next.
So good evening, everybody.
Yeah.
All right.
Good
Okay, to
evening.
go, Gabriel. Yes, good evening. So in the next 2 slides, I'll quickly take you through the evidence on suturing technique, because the evidence does show that suturing technique has a significant impact on the clinical outcome, and that the small bites technique that we're speaking about today has a significant positive effect on wound infection reduction and incisional hernia rate reduction. I think the most important example of that is the randomized controlled trial by Milburn in 2009, where they compared the small bites technique with the large bite technique that a lot of people still use, and it showed that the small bites technique has a lower rate of surgical site infection and incisional hernia. And when they did a multivariate analysis on that, it actually, taking all the parameters into account, it showed that the risk of infection was twice as high, and the risk of incisional hernia was 4 times as high if you take big bites and compare it to the small bites technique. And the second study, the Stitch trial from Edinburgh 2015, showed very similar results. Also randomized controlled trial, showing that the small bites technique is more effective in the prevention from incisional hernia after midline incision, and it's not associated with a higher adverse events. Can we have the next slide, please? So what is the small bites technique? And I think, we're all aware of it, but we're not all doing it. And the small bites is that we take a width of the bite of the fascia of 5 to 8 millimeters, and we progress our steps along the fascia with a small interval of only 5 millimeters. And that's, I think, where many of us go wrong. For the sake of time efficiency, we try to progress faster. In those bites, we only take the fascia, the aponeurosis, so we don't take fatty tissue, we don't take muscle tissue or peritoneum, just the anterior fascia. And that small bites technique gives us a better distribution of the tension. And because we have a better distribution of tension, we have less tearing. Less tension also gives a better wound supply, better blood supply to the wound, and gives us better healing. And the evidence shows that the small bites technique can reduce abdominal wall complications by up to 50%, so less incisional hernias. The question is, why are we not doing it? And by some people, it's perceived to be difficult, but for many of us, it's perceived to be time consuming, and at the end of the procedure, we want to progress quickly. So when we look at studies, we saw that even all the surgeons who know the evidence of the technique, still only 24% adhere to the technique properly. And that's where Gabriel had a brilliant idea. So now I'll give the word to you, Gabriel. Sorry for cutting in just now.
No. Thank you, Jan. Okay, so we want to help surgeons and definitely patients to have a high quality fascial closure. So we ventured on developing a device, and this device has a guide that facilitates stitch placement. So if you direct the guide towards the previous stitch and towards the incision, you will get the optimal step interval and bite size. And we have been able to show both clinically and preclinically that the success rate of suture length to wound length of 4, which is the correct quality assessment, is about 100%. And we know that the device is fast. In this very tiny figure, you have the closure time on the x-axis, and you have closure quality on the y-axis. And the blue dots are individual closures by the machine, and the red dots are individual closures by hand. So a lot of the hand closures are below the desired 4:1 ratio. The closure time is about 30% quicker if you use the device compared to manual closure. Another nice thing with the device is that it is safe to use. The needle is you don't need to manipulate the needle with your hands, and when you lock the device, the needle is kept in the shafts, so you won't get any sharp injuries. And we have been able to show that there are no sharp injuries when you use the device. Okay, let's see. Next slide, please. So this is a film from a cadaver trial we did. When you compress the device, a needle shuttles between the shafts and can propel the suture thread through the tissue. And compared to manual suturing, this is a very fast way of doing the closure. Okay, next slide, please. So what we want to say to you is that there's a lot of evidence to say that small bites reduce the risk for complications such as wound infection, wound adhesions, and incisional hernia. And even though it can be complicated to do this,
so even if it can be complicated to do this, we've seen that it actually has it reduces the risks of complications. There's also the discussion of what suture to use, and the evidence shows that we should use a slowly resorbable suture like a PDS. And I think a lot of gynecologists have a tendency to use Vicryl. We use it for many things, but for fascia closure, we should aim for a PDS. And also an important factor is to have a running suture with the suture length to the wound less than 4. So to have many many tight stitches. Okay, thank you. Next slide.
I think that was the last slide of the presentation as such. So thank you very much. And indeed, we wanted this to be a discussion more than a presentation. So now I think the panel has introduced themselves. And so thank you for that. But I wanted to ask Dr. Weil, you know, from your perspective, why do you think this is important, being a gynecologist, and also what's your experience in this clinical space, how much this clinical guidance is followed?
So it's definitely, we always try to seek devices and improvements in our daily clinical practice. I mean, cesarean sections, we've been doing cesarean sections since years, and it's been done since many, many years. But it's always about how to be better and how to improve. And definitely, like, I mean, you know, the energy devices, when I'm just giving another example, we didn't have energy devices, so things like the, you know, the ultrasonic or these types of devices, which make our lives really much easier when we are doing a hysterectomy, for example. However, yeah, now they are available and they make life easy doing these surgeries. So the same with such thing, and they're safe. So you look to the patient safety and you look to the better surgical outcome. So definitely closing the fascia, I mean that this is a fact that small bites will help give more support to the fascia. The thing with gynecologists that maybe we do not experience much these types of incisional hernia because we don't come to know about it, because most of those patients, they will develop, this is most of the time, it would be a long-term complication, and then they present to the general surgeons for a repair of the incisional hernia. However, like discussing with several of my colleagues, general surgeons, unbelievable that the statistics are high. And I personally, I just had a patient who had an incisional hernia after a cesarean section. She was an obese patient, and we repaired this incisional hernia just a couple of weeks ago. So this is a complication that can happen with any of us, and definitely the small bites can help improve the outcomes.
Thank you. That was a very insightful response. But I wanted to invite Dr. Backeland as well to this specific topic about, closing in C-section specifically, but maybe also give your perspective on, the type of risk patients that potentially would be a candidate for a midline incision in a C-section. What's your experience with that?
Yeah, so I think different things. I think for one, I think there's still an issue of awareness amongst gynecologists, and we're all involved in this, and general surgeons are very aware, but I'm not sure that all gynecologists are aware that we should be doing the small bites, and then even it knowing that we should be doing. The truth is that most of us aren't doing it on C-sections, because it's supposed to be a quick procedure for us, and we want to gain time, and we want to finish quickly, which is important for the patient recovery as well. So I think seeing our C-section rates going up globally, you presented the UAE data a while, but they're the same in most countries. I think the Scandinavians are quite the exception on the rule still, but in Belgium we see the rates going up just as well, and seeing the data that Andrea presented, that with every C-section we do more, there's like a threefold increase of herniation. This is something that we as a profession must become more aware of, because we're going to see more and more of this, and that goes, I think, for the funnel steel incision that we use as well. We should be suturing that properly as well. Midlines, the midline incisions aren't that common in C-sections, but there are the groups of complex cases with malpresentations and multiple C-sections of or multiple pregnancies on very small babies. So there is definitely that group, but I think that is a minor group where we should definitely be aware of the way we suture. But I think the important group is actually our group with lower transverse incisions, especially on the high BMI patients that have a higher risk, on our patients with comorbidities, the diabetic patients that we know don't heal well. So I think there's a big population in the lower transverse incisions that will benefit from proper suturing, and if we want to do our proper suturing quickly and efficiently and correctly, this is a device that can definitely help us with that.
Thank you, Dr. Backeland. And I also want to invite Dr. Stewart. Being head of a clinic here in Sweden, what's your experience, and how is the conversation and discussion between you and your colleagues around the closure techniques when doing a C-section?
Yeah, so I think just as Dr. Backeland said, that there is an unawareness among gynecologists how to close the fascia, with what suture, what is the evidence. At our department, we are aware of it, and the younger colleagues are taught to suture, with the small bites technique. But of course, if it's 3 a.m. and they're in a hurry and the delivery ward is calling, I don't know if it actually is performed. And I think, and at those times, speed is an important factor to be able to close quickly when we're disturbed by the delivery ward, for example. I also think when we started to be more aware of the evidence, that we switched from Vicryl to PDS. We previously used Vicryl to close the fascia, and I think it's quite common among gynecologists to actually do that. So that we've also tried to use the correct suture. And I also wanted to, it's not only the cesarean sections. I mean, after cesarean section, there's the risk of hernia, but there's also increased risk for other abdominal wall complications, endometriosis in the abdominal wall, or that the uterus can get stuck to the abdominal wall. So I think we as gynecologists need to focus more on correct suturing, and at least trying to identify the risk patients: obesity, previous cesarean section, smoking, diabetes, maybe old age, I don't know, and give a little extra attention to avoid long-term complications in these groups of patients.
Thank you very much. And you mentioned the type of suture and the properties of a suture. So I would kindly ask the founder of Centurion and also the trauma surgeon, Dr. Berner, if you could elaborate a little bit why it should be a slowly absorbable suture and what type of properties this type of suture should have, and also about, the tension. So I think that's something that is also a very important part of doing a correct closure, so the tension of the suture. So Dr. Gable, would you like to elaborate on that, please?
Yeah, we know that the fascia heals will heal slowly over the year after a laparotomy, and it has maybe 30% of its strength after 4 weeks. So we need to have a suture that is slowly resorbable. It can't be gone after 2 weeks. You need a suture that have a certain strength until the wound is strong to support itself. That's very important. So a slowly resorbable suture is perfect. A PDS or a PDO, which is the same formula, would be perfect, but there are, of course, other sutures. The tension should be a maximum 1 kilo. That is you should be able to see the thread in the wound after. You should see the suture line. You shouldn't lift the patient. I would just like to say another thing also that's I think it's strange that we have a fantastic opportunity actually to reduce complications by 50% by just putting in either using a device or put some extra 10 or 15 minutes when we close the abdomen. So it's a fantastic opportunity actually to help our patients to be thorough when we close the abdomen.
And why not Vicryl, Dr. Berner?
Vicryl is super slow resorbable. It's gone before the fascia have had the chance to heal. So it's not a proper suture for a fascial closure.
Okay, and it's also what type of is it multifilament or monofilament?
Yeah. I think the reason for not using Vicryl, I think, is not actually that it's multifilament. Maybe there's a slight increase in infections when you use a multifilament, but the main reason for why we should not use the Vicryl is that it's too, it's gone too fast.
Yeah. Thank you. Yes, Dr. Well, please.
Yes, so referring again to the region here and to what Dr. Stewart said, that with multi-para patient with previous multiple cesarean sections, with obesities and diabetes and so on. And unfortunately, like after moving from Germany and practicing here in Dubai for the last 3 years, we really have a high incidence of high-risk patient here in the region. I think so. Maybe also there are cultural factors. So it's definitely on the contrary to Europe. So the parity is much higher, and the rates of CS or cesarean sections are higher. So I mean, in Germany, it was, I don't know, every couple of months that I have a patient that had 3 previous cesarean sections, for example. But here, nearly on daily or weekly basis, you have a couple of those patients. In addition to obesity and so on. And that's why I really realized that such a device can give us better support with the outcome that we're looking for.
Thank you. That's a very insightful comment. But I also want to invite the rest of the attendees here. If you have any questions, please place those in the chat, and I will forward to the panel here. Again, Dr. Backeland, I mean, you obviously you have a global exposure. You are the inventor of the V-Notes technique, but you also are a very prominent gynecological surgeon overall. What's your experience with these type of situations in the middle of the night, standing and doing a closure? Is it a situation where you think about the small bite technique, or is it just about to close as fast as possible? What's your perspective?
Well, I should say that I use the small bite technique every time, and I think one of the things that we've talked about, we haven't stressed a lot yet, and that made it click for me is like, oh, I'm not always doing this correctly, is that 4-to-1 ratio, which means that you need to use at least 4 times as much suture material as the length of your wound, and when you think of that when you're suturing, you realize that I'm not doing this most of the time, and now being very aware of it, we try and we teach it. But that's, the 5 millimeter is one thing in your head, but if you think actually, I really need that much suture, then you realize like I'm not doing it. I'm not doing it good enough. I think I'm doing a good job, but I'm not doing it good enough. And I think that goes for all of us, or for a lot of us. And of course the problem is, and we see that especially in oncology, in open oncology surgery, where we have large abdominal incisions, is like, we're happy and we're satisfied when our debulking surgery is finished, and then it's the wound closure, and we don't give that the attention that it needs anymore, because we're tired and we're starting to think of the next thing, and we're talking, and I think those are, as Gabriel says, those are such big opportunities to reduce our complication risk, by a factor 4 for incisional hernia, by a factor 2 for wound infections, that it's not something we should miss. And now, being in contact with Gabriel for a while, and having learned how to do it properly, I'm much more aware of it. But I know that in the C-sections at night, many of us just don't take the time to do it. That's just a reality.
And if you had a device, if you had some type of technology innovation, I mean, the device that we have shown here, you can still do large bites with that device, right? So, but just holding it in your hands, do you think that would mean something?
I think the strength of the device is that it sort of automatically makes you use it the way it should be. That's the way it's designed, is that, if you put it intuitively where you want to put it, with the corner on the previous suture, you automatically get that 4-to-1 ratio, and you don't have to think about it, and you can do it quicker, significantly quicker than you do it with, if you do it with a needle driver. So you're not, you're going to be doing it better, and you're doing it in the same time or quicker than what you're doing in a way that you're not doing it correctly now. So I think that's the strength, and I think it's a safety issue as well. We spoke about needle injuries, but I think there's also the safety on the other side of the fascia, where we can have a risk of suturing bowel to the fascia, and having this device having an arm under the fascia, picking up the needle, you prevent that risk as well. So I think it's a safer way to do it. It's a more efficient way to do it, and it's the correct way to do it.
Yeah. Thank you. Dr. Stewart, yeah, You raised your hand very timely there. Please.
No, so I was just thinking, we were discussing before what measures can we what can we do to suture the correct way and to avoid complications? And one thing was to when we start the surgery to spend time to free the fascia, because it will be easier to suture it correctly in the end. And we haven't done this, but after a long surgery, it could be an idea to have a new team come in and close. Because if you operated for 5-6 hours, you're tired. But if you have somebody new come in that's happy and alert and just takes time and does it properly. And I also wanted to ask Gabriel, who's the abdominal wall surgeon. You know, I see sometimes how colleagues tent up the fascia. There's a lot of tension in the suture, and or they put peongs on the fascia to try to mark it out. Do you have any comments? Is that a good idea, a bad idea? Does it matter?
No, I think you should manipulate as little as possible with the fascia and adapt the fascia with as little tension as possible. You shouldn't need to pull the fascia, because then you overstretch it, and then it will be prone to ischemia, and it won't heal then. I just want to add also that we shouldn't forget that abdominal wall complications is one of the most common reasons for patients not following their chemotherapy after surgery. So it's very important to keep track of all the things we do as physicians. And as this is a great opportunity to reduce complications, I think we should put a lot of effort in closing the fascia correctly. No, not much tension, small bites. Do a precise incision when you open the abdomen, so you don't open the muscle compartments. And then it's much easier to close the abdomen, and faster afterwards also, when you see so you can see what you do.
Dr. Well, considering what just Dr. Berner said here about the closing and the opening as well, of course, in your clinic, do you allow the younger surgeons to close, or what's the standard in your clinic, in your department?
Yes, so actually, most of the time, we allow our registrars or younger residents to close the wound. Like when they're still in their first years of practice, usually under supervision, but most of them, they're very well experienced by now to close the wound efficiently. I always try to recommend the small bite closure, and I try to do it myself as much as I can. So yeah, that's the practice that we're doing at the moment.
And how do you think potentially a device or an innovation would that in any shape or form help the younger surgeons to do a better closure? Or do you think it's still that you need to do, you need to go through the basics with the needle driver, and then potentially you could add some technology? Or what's your perspective?
I mean, the good thing about that's a very good question. The good thing about the device is that, like Dr. Bakeland said, it gives you the feeling to do it. It pushes you to do the small bites, and that's a good thing. However, of course, I mean, manually you can try to do it, but would it be that efficient? I've personally tried the device. And I've used it, I've practiced on it, and I really see that the precision in taking those small bites are definitely more effective with the device than if we're doing it manually. Yeah.
Dr. Bakeland?
Yeah, I have a question for Dr. Berner still, and I know he put a lot of thought in developing the device and choosing the suture, but we haven't spoken about the needle yet, and I think that's something you looked into, and I see a lot of gynecologists closing fascia, and I see a big variation on sutures, but also on needle type. People using very big needles, using smaller needles, using cutting needles, using just a pointed needle. What is your expertise? And even when we're not using the device, what needle should we be using? What should we be thinking of?
Yeah, most studies that have been evaluating small and large bites did that by randomizing surgeons or patients to be close by a big needle and a small needle. And I think the general feeling is that if you have a very big needle, you get a lot of momentum and you trash the fascia. But to put small bites, it's very good to use a small needle that would be around 2 centimeters in diameter, not a big needle. A small needle is perfect because that prevents you from taking large bites, including the fat or muscle tissue. So small needles, that's good.
And going straight through your device, it goes straight through. You like if we take a bend, do we put more damage to the fascia? Is that an advantage?
Yeah. I think that's debated. We did a small study that we are doing the manuscript on, comparing straight needle that goes directly through the fascia and a curved needle that pulls the fascia, and we found that you need more tension or crush pressure with your tweezer or pin set in the fascia if you use a curved needle compared to the straight needle. But otherwise, but that's the only situation that I have seen any science or measurement of the difference. But I think the general feeling is that you big needles at least make bigger holes in the fascia.
Interesting. Dr. Stewart, I was, I want to go back to you because when I look at this picture that we see right now with apparently small bites, what's your, when you see the distances here between the stitches, and you think about the colleagues and the residents that you have in your clinic, are you confident to say that this is the distance that they close?
Yeah, I think since I work close to Gabriel and we've been discussing this for quite many years together, we've increased the awareness and the education at our department. So yes, I think that they actually suture with 5 millimeters apart, and we measured the length of the suture after the surgery, and if it isn't long enough, we resuture. So you only need to resuture once to do everything to avoid ending up in that situation again, that somebody cuts up your whole suturing. So I think at our department, yes, but we've been, we have a tight communication with the Department of Surgery on this topic.
Yeah. And if there's a patient that would experience abdominal wall complications, ranging from the very short-term complications like SSIs or burst abdomen, where would that patient go in your hospital? Who would take care of
They
it?
would go to us, and we would take care of the within 2 weeks. We would take care of the complications, or a month, and then we refer them to the Department of Surgery. We would resuture the fascia if we have a dehiscence if it's a couple days after surgery. But long-term complications, we don't even see the patients. We're not even aware of them. So I think we underestimate the risk of complications. And I was also just, when it comes to the type of suture, Gabriel, I wanted to hear what you think about barbed sutures, because that's used for everything now. People are using barbed sutures. Should we use a barbed suture on the fascia?
Yeah, well, it's under heavy debate, I would say, because the whole point with a monofilament suture is that it can relieve the tension from the individual stitches. So you get a similar tension on, you divide the tension on each stitch. But if you use a barbed suture, then you have a fixed tension. So what does that mean? I don't know. I don't think there's any science to point in any direction so far. But I know it's in Europe. It's a south and north thing. It's not used in the northern parts of Europe, for at least not for fascia adaptation. But we'll see. I don't know. It's like it's counterintuitive for me, because then you wouldn't divide the tension on all the stitches. But we'll see what the science says.
Dr. Well, please.
Yes, so actually, I got two messages now from probably one of my colleagues that is attending the webinar. And she's asking me, when can we expect this this device here in the country? So that's the first question. I'll probably be referring this question to you, Pan.
Yeah.
And the other question is, would I, so as a head of department, be using this device for all of our cesarean sections in the hospital, or for all of my cesarean sections in the hospital? Well, actually, I'd love to. And whenever it's possible, I'll use it because, I mean, if I have an advantage of more secured abdominal wall closure and better outcomes, then I'll definitely go for it. But I will definitely go for it at least for high-risk patients with previous surgeries or repeat cesarean sections or obese patients and so on. So I'll go back to the first question, and the mic is yours, Ben.
Thank you very much. Thank you. Yeah, so just to give a little bit on an answer to the question on when this will be available. First, I want to say that developing a medical device, a relatively simple one like this is, because it's only mechanics, there are no electronics or chemicals or anything like that. It still is very challenging today, and it requires a lot of money. But we are very close now of launching. We do expect to have FDA approval early 2025. We do expect to have CE mark approval late Q1, early Q2 next year, and which means that we can, with the FDA approval, that will have probably January, February, that we can start the approval process for UAE and the other Gulf countries. So, and then there's a bit of a process to get that market approval, market clearance. But I do believe, and trust me when I say this is something I'm really looking forward to, but I do believe that this will be available in the Gulf market late Q1, maybe even sooner. But you know, and we as a company, we also have some things that we need to finalize to be able to provide the best possible quality and the best service for the users as well. But late Q1, I would say, for UAE at least.
Fantastic. Thank you. Thank you.
Yeah. Yes, Andrea.
Yeah, so I was both Doyle and I work as the head of our department, so there are always the discussion about costs. You know, we want to use different devices, but then there are the cost issues. I think it's like most other devices. once you start using it for one indication or one patient group, and then you realize, oh, this is so much easier, so much quicker to use a sealing device or to use whatever equipment you use, you kind of tend to broaden your indications because it just makes life easier when you operate. So I think in our department, it will also be, at least in the beginning, for high-risk patients, and then we will see how things evolve over time. Oh.
Feel
And
free to use
something
it
that yeah, but something I also want to discuss is, or just mention, is the cost of complications, because we focus on the perioperative cost of a device, but we need also to take in the real cost, which is also, if we have abdominal wall complication, the cost for that patient will be a lot higher than if we could have avoided the complication. Yeah.
And maybe I can just mention there that we at Centurion, we asked a third party, an institute, to do a health economic evaluation of this device. So Centurion did not do it. So this is an objective third party. And that health economic study shows clearly that there is a economical benefit of using the device, ranging from the shortened operation time, but also the reduction of complications when doing the small bite technique. But I do believe and using the device for the more complicated patients, the more risk patients, is what we do expect also to see in the different clinics and hospitals around the world. Yes, I think we almost consumed the full hour. First of all, I want to open up if there are any questions, any comments from anyone, or if there's anyone in the chat, or anything from the panel. Any final words from anyone in the panel? No? Okay. Yeah, Jan, please.
I think we're all dying to try it out in real life, Pan. So get it to us quickly. I think that's a final comment. I think we're all convinced of the benefits. We just want to get our hands on it now.
Yeah, I'm happy to hear that, and I can tell you the team is here at Saturn is working day and night now to finalize everything for the launch, both for quality and for regulatory side, and also to with our distributors in the local markets. But we're happy to hear there's an excitement around this technology. A big thank you to the panel. I think and hope that everyone was as intrigued as I was listening to the comments and the insights. There is absolutely, as we see it and I see it, there's a need in supporting surgeons to close better, if I may say it like that. This is the final thing you do before you go and do something else. So I've been in the operating room myself several times, both with surgeons who paid a lot of attention to the closing and surgeons who have done it very, very fast. And I know sometimes the frustration in the operating room when people just want to move to the next step. And hopefully this device can help and support everyone to close faster and better with higher quality. I also want to say thank you for everyone who attended. And if you have any comments, if you want to know more about Centurion, please feel free to reach us through our website. And you have our contact details there. There's also availability to sign up for a newsletter. And personally, together with one of my colleagues, I'll be at Arab Health late in January. So if someone wants to meet us together with our local distributor, please feel free to reach out as well. By saying that, I want to conclude and say thank you and wish everyone a very nice evening, and take care, everyone. Nice meeting you. Bye-bye.
Thank you.
All right.
Bye.